Good afternoon and welcome to Facebook Live. This is Dr. Blvd, Chief Medical Officer at CGH Medical Center. Thank you for joining me today on March 24th, 2022 for this broadcast. So today I want to give you the roadmap of the broadcast. We're going to start talking about palliative and hospice care with Dr. Reter and get into some depth about that issue, that situation. And when we're done with that, then I'll give a brief pandemic update. So that, in a nutshell, is the roadmap. And with no further ado, let's get Dr. Reter on with me today. Hi, Dr. Reter.
Hi, Bill. Thanks for having me.
Well, we're glad to have you. Glad to have our repeat folks on.
Sure.
So this is an area that Dr. Reter knows a lot about. He's been involved with palliative care and hospice for a long time. Matter of fact, I'll let you kind of tell the folks, just so they have some sense of your depth of knowledge of this. You can kind of give us a bio on that, if you would, Jay.
Sure. Well, I'll start with saying I'm sort of second generation hospice provider, as my dad was active in hospice care in my hometown of Canton, Illinois, and since the early 80s. And then when I came out to start working, which this summer will be my 21st year of working here at CGH, I was offered to help out and participate in our local hospice. And I've been the medical director at Hospice of the Rock River since 2003. So I've been doing it ever since.
Yep. Yeah, so just so our viewers get a sense that Dr. Reter knows the ins and outs of this, what we're going to be talking about today. So,
yeah.
Okay, so let's get at it with some of the questions, Jay. So the first one that I had that I wanted to run by you was, how would you define palliative care versus hospice care?
Sure. So palliative care is kind of a word that's being used a lot more. In its most general sense, palliative care is any kind of care where you're treating any kind of pain. So some people, in a very basic sense, say just giving Tylenol for a headache is officially palliative care. And so much of what we do in healthcare is about educating people, keeping them comfortable, making sure that all of their needs, physical and emotional, are taken care of. And that's what palliative care is. And the way it's being used right now, palliative care as sort of a subset of medicine is care that's being provided usually in the sense of someone who has a severe illness, and that can be a cancer, that can be severe heart disease, COPD. And it's talking about bringing a team of people together, including your physicians and support groups, to make sure everybody has what they need. Now, hospice care is specific for end-of-life care. Hospice care is care for people that have a terminal illness. They have a disease that is not treatable, and they don't want any further aggressive treatments for it. Usually, hospice care carries sort of a 6-month prognosis or less that the doctor sort of defines. So palliative care and hospice care is palliative, but palliative isn't restricted for people that just have a terminal diagnosis.
Okay, yeah, that makes a lot of sense. And so you already alluded to that hospice care, the time frame is the window that you get hospice care is typically that 6-month or less window. What's the time frame for palliative care, Jay?
Well,
is there one?
There kind of isn't one, and because palliative care, really, it's a process where patient and provider, patients and their doctors are trying to communicate well. Its goal is all about communication and treating kind of all of the needs of the patient. There are some big facilities that have a huge palliative teams that really almost work exclusively with the cancer patients, or sometimes with the end-stage heart disease or COPD. And they have physicians and teams that kind of come in to make sure that there's nothing being missed, or making sure that they kind of fill the gaps of questions. kind of locally, our philosophy, my philosophy, and I think I can speak for the CGH as an institution. We try to keep that philosophy that our primary care doctors, our the patient's doctors, whether they be their cancer doctor, their cardiology doctor, are the sort of driving force that are working within palliative care.
Yeah, good. Before I go other questions, just for the folks who are listening to us right now live, as always, if you have questions that come to mind, please send them our way, and we'll do our best to answer them for you. And one other piece of bio on Dr. Reter, I don't think I mentioned this when I introduced him. Dr. Reter is a family practice physician and has been here at CGH, as he mentioned, for over 20 years. So that's where he comes to this issue from. So I just wanted to be clear with that. So next question I want to run by you, Jay, is when you see resistance from whether that be from patients or families to receive, let's just say, hospice services.
Sure.
Are there any common themes, and how do you address, or would you address these concerns?
Well, I guess you have to sort of find out where that might be coming from. Now, some people are resistant for good reasons not to have hospice. Maybe they're not ready. If you're not ready to keep, if we use the example of cancer, if you're not ready to stop being aggressive about your treatment, and many times it's appropriate, you want to keep treating it. But if it comes to the point where your treating doctor says that further treatment is sort of futile, or maybe patients have said they just don't want to do the treatment anymore. We've had some of our patients who have decided they don't want to do dialysis anymore. Then they come to us. But there's also a sort of many people don't know that hospice services are available as another option. So there's I try to do a lot of education like we're doing today, that this is an option, that if you've got a terminal illness and you don't want to keep pursuing aggressive measures, there is another treatment option. And I mean, I can go into further all of our hospice options right now, or what we do and what we provide. But I think the biggest resistance sometimes is, one, they're not ready, and sometimes that's appropriate. Two, we sometimes have issues with patients are ready, but family aren't. And then it's a matter of kind of communicating to the whole family what is everybody's expectations, what do we want, what do we want to put your loved one through, and always, most importantly, what does the patient want? Is this something that your mom would want, your dad would want, grandpa would want? Is this you want to put him through this? Or so kind of teasing that out is always sort of a very important determination about whether or not someone should go into hospice, or what those barriers are.
Getting everybody aligned to what the patient's wishes are.
Yeah, what the patient's wishes are. And then, but also trying to make sure that the patient's wishes, we can get everybody on the same page. This is what mom wants. This is what they want, and then it makes easier trying to make the whole family communicate and answer the questions that they have. Just makes it easier for everybody, but especially for the patient who's going through this.
Yeah, good. And you've already alluded to this in our conversation already, Jay, but people tend to think of, I think most people think of hospice and they think of cancer, which is very appropriate. But there are other things that qualify for hospice care. Can you speak to those as well?
Yeah. I talked about end-stage kidney disease, or people that are on long-term dialysis who decide they don't want to do that again. We have, some people that have end-stage heart disease or end-stage heart failure that don't want to keep going back and forth to the hospital, or the traditional medications are no longer working, and they become recommended for that. End-stage dementia, of multiple different types of dementia, often can progress to a point where patients stop eating and start losing weight and get weaker and weaker. And then that is an appropriate hospice diagnosis that can come to us. Whenever there's a question about hospice and appropriate care for hospice, we tell patients that we'll do the referral, we'll talk with the doctors, and then we'll kind of make a determination if hospice is appropriate. And there are some times where patients come to us, let's say we've had patients come to us with strokes is another good example, where sometimes people have a very debilitating stroke and they're not making a recovery and they come into hospice care. Okay. We've had some people who surprise us and they live longer than 6 months. Okay. Sure. And sometimes that's appropriate that they still have a terminal illness and they need to stay with us. We've had people here on our hospice service for much longer than 6 months. Other times people get better, and we say, well, you know what, you're doing so well that it looks like, and we don't just sort of cut them off. We still have we still check in with them frequently for at least 3 months after they're discharged. And if their doctors or the family think there's a decline and they need to come back in hospice care, we've had a few people who have sort of kind of graduated from hospice and that they're doing better and they go off hospice. Yeah. But we always kind of leave the door open to patients and family that if something's changed or deteriorate, we will appropriately come right back to you.
Right. Because really the reality is, when they ask you or me to determine whether you think someone has 6 months of life or less, we're our best educated guess is that it's less than 6, but you just don't know.
Yeah, I mean, we just don't know. And I've been doing hospice care and end of life care for a long time, and I often will say, I know enough to know I don't know, because people will sometimes surprise us. And then sometimes we have patients who sort of make a decision that they're done, and I don't know how they just seem to shut down and they're done. And other times people make that decision, but their body kind of just isn't ready. So that's when we just, that's especially good. And we do try to have our hospice services available for people early, so that sometimes people think that hospice is only appropriate for someone who is actively dying, or looks like, well, we knew they had this terminal diagnosis, but we didn't call hospice because, they were still doing okay. They were still going to church or still visiting family, but no, and if anything, it's better to have our hospice services on sooner so that we can give all of the support. And I'm going to follow that up with saying, hospice services we can do it. Our goal is to do it at home, people's homes, but we have, but sometimes we can do it in at the nursing home, sometimes at the hospital. But our services includes nurses that will come in and check on the patients and are actually available 24/7 if a crisis occurs. They don't live with the patient, and we don't provide in-home care, but we do also have aides who can come in for helping out with baths and basic care. We also have our social service, our chaplain service. We have great volunteers that can come in and help. Some people need a lot of these resources, some people don't, and we also kind of assess to see what people need. And then I think something else that's overlooked, I try to say it again, but I'll reemphasize it, is we also have the services to the family, because it's stressful, and many people, they haven't talked about this before. They don't routinely want to talk about death and dying, and now we're talking about it and what to do and what to expect. And so so that's why we say that if there is all those resources available to the patient and the family earlier in the illness, rather than just when they're seeming like they're about to pass, it's better.
Yeah. And by the way, thank you for those of you who are posting comments as we're talking. Thank you very much for those. You also alluded to this. I just want to go in a little more detail about this,
Sure.
about the idea of if you're on hospice, what that means in terms of whether you can go to the hospital and get
Sure.
hospice in the hospital, and even sometimes about the whole DNR status and all that. Can you talk a little bit more about that?
Okay, so several things. I mean,
Yep.
so in general, if someone has a hospice diagnosis, we try not to do one. It's accepting in the cancer patients that we're not going to do more chemotherapy or
Right.
keep fighting in that regard. In patients with end stage, heart disease, we're going to try to avoid any hospitalizations to give IV medicine to take fluid off, but we'll still give oral medications if needed.
Yeah.
So the hospital is really used as sort of a last resort because it's all about sort of comfort measures. We do often take people on when they're in the hospital. I mean, oftentimes these decisions to go hospice happen in the hospital.
Yeah.
And when families are talking with the hospice services and patients, it's with the aid of the social worker at the hospital. They come there and talk with the physicians and then make that decision. Hospice usually then starts once the patients are discharged, okay, and then we'll take over more fully, because I think our hospital does a good job of, when they're in the hospital, we have comfort measures and appropriate staff and physicians in place who know what to do. So then they can be either discharged to their home with hospice, or if their home happens to be a nursing home, sometimes we do let them go back there because that's their familiar place.
Sure.
Still other times, if it's not feasible for them to go home, or maybe they have some symptom that's not under control, they can consider doing a inpatient hospice facility. Locally, we have our hospice house, Rockford Hospice of the Rock River Hospice and Home. Has a hospice house. It's here in town across from the YMCA. It's been open 5 years now. It's been a great resource for our community. Oregon has a hospice house in Serenity Hospice House is there.
Yeah.
There's other hospice houses in larger communities, but these are in our Northern Illinois area. That's the only places we have that service.
Yeah.
And so that can be very much a relief and kind of a backup plan for our patients and families, where if for some reason there's loss of a caregiver, there's no one at home to take care of the family member. I mean, oftentimes we have people in hospice and the primary caregiver may also have multiple medical problems and something happens. So then we can shift them to our hospice house and take care of them then, or again, pain crisis, any kind of things like that.
Yeah.
When they leave the hospital, hospice, the home can then be a place where we make sure all the medications are in proper place, and then we can get them to their home, the real home. So we have a lot of options, and we're used to sort of transitioning, and we're very flexible about where we can bring people in and out of. But our goal still remains to do care for hospice people, for hospice patients in their home.
Right. I ran into the family member of a former patient this weekend, and they had mentioned that, and the patient had passed away, and I mentioned, I said, sorry to hear that, and they brought up unsolicited, really, that that patient had gone to a hospice home, and that had been really helpful, because they had wanted to be able to die at home, but it just wasn't a good fit with everything. And so having a hospice home that they could go to and was very helpful. So anyhow, it's great to know that that's there, and that those kind of services are now available, where probably, I'm guessing 10, 20 years ago, when you started your practice, my guess is there weren't tons of those.
No, I mean, they were just some of the major cities were starting to have some of them. And, but
Yeah.
we thought it was sort of out of reach to have it here. And then
Yeah.
we, as a service, kind of made it a priority, and we had fundraising, we had generous donors, and we were able to get one in our town. And it's been
Yeah.
really a great resource for our community and for our hospital. And I've been really, and again, when they were talking about getting the ready, I didn't have the vision that the rest of them did. And once I got there and I saw that, there's 6 beds, and there's rooms for families to interact in the kitchen and dining room areas so they can then get away. And it really is a very comfortable place, which is, again, trying to make the best of these hard times.
Yeah.
It makes it easier.
Yeah. I want to key in on another thing that you've already kind of talked about some, but just to talk a little further, just so folks understand clearly, what are some things that hospice provides, and what are some things that they don't provide? So when people have a sense of the expectations when the patient aligns themselves and the family with a hospice agency. And by the way, there are multiple hospice agencies in their area, and they all do a really nice job. So
They do.
I just want to make sure that we're clear about that too. So if you could just speak to that, Jay, in terms of what's there and what's not there in terms of expectations.
Sure. I think what's not there is 24/7 care. I think some people would like that. The hospice can help. The ones that are non-for-profit do have usually ways. It's covered by insurance. Medicare hospice services are, and we try to make every expectation of what's not covered be covered by the charitable portion of the hospice. And again, what's there is the team of nurses and nurses aides, social workers, chaplain services, volunteers. That's good. Again, I think the thing that's not there that some people want is the 24/7 care, and that we can help set up with resources, but that is still kind of impossible. We don't have that degree of resources for the number of people that we care. I mean, I think we do a very good job meeting the needs for our families, but that particular issue is, I think, one that families hope for. And I wish we had the degree of resources to do that, but we just don't.
Right. That makes sense. Okay, good. I just want to clarify for folks. And
Yeah,
my guess is sometimes those are the patients whose expectations or need a little bit more than what you can provide at home. That's when those patients at times will transition to some hospice house, whether that's in this area or another area,
sure.
to help out a little bit more.
Absolutely.
Yeah.
Absolutely.
Okay. So, you've been doing this stuff for a long time, Jay. I know you're a big believer in this type of care. It's pretty obvious as we're talking that I know you're very, and I know I've known this for a long time. You're very passionate about this work. Can you? Well, obviously, we can't go into, but for HIPAA reasons, we can't go into particular names.
Sure.
But would you be willing to share maybe a story or two about how you've seen hospice benefit
Sure.
a patient or their family throughout the years?
Well, I've seen. We have so many stories, of course, and sometimes the ones that are new are the freshest. But some we've had patients who were. I think that the recurring theme we see a lot are, we get someone the care, we get them comfortable at the hospital, or at the hospice house, and they're like, wow, we didn't even know this was available. Thank you so much. We didn't really know what we're getting into, and you guys made it so easy. And we didn't know all the support, and you guys were kind of right there, and that's been great. But I mentioned before about in the past when we didn't have a hospice house, we would have to urgently put people in a hospital or a nursing home. Having that service, patients have been really super happy about, and I was really, really thankful to have that. I've had great experiences, difficult experiences, seeing some young people who had end-stage cancers and having to go to their homes and talk to the family and kind of talk to them. Sometimes it was just sort of hearing another face saying that you're doing all the right things and this is all we can do. And that part has been rewarding to know that I can help people in that way to understand what we're doing, why we're doing it. But yeah, I get passionate about it because sometimes hospice was born from a place where back in the bad old days where they did absolutely everything, like in the 60s and 70s and maybe even the early 80s, you do everything for people no matter what. And there was all these interventions that were done that seemed like they were doing them because they could do them, not because they should do them. And now I think we're much better about recognizing futile medical care, not putting people through unnecessary procedures, and letting the patients and their families guide us on how we should treat them.
Yeah.
And that's good.
Yeah, it is. I'm obviously not as involved as hospice as you have been through the years, Jay, but I will say in general, what I've noticed about patients and their families is it's almost like for those people that the stories that I hear either during or after the fact of having had a hospice care, it's like the family and the patient, their anxiety level and their stress about what the illness brings to that family dynamic is really high a lot of times. And when the hospice agency gets involved, whatever the hospice agency is, it's just like that just goes down.
Yeah.
Because you have folks who can answer your questions, who have been through it, who, can meet some needs that you're just without that service, you're just not able to do. And it just brings down the anxiety in the rooms, and then it almost is like, then for the families as well as for the patient, then you get an opportunity to actually, in a good way, experience what the process of dying is like.
Sure.
And
goodbyes and that's what we're going for. Relieving that kind of pressure from families and patients as best we can. Again, it's going to be a hard time no matter what, but trying to make that hard time as easy as possible and fulfilling and often meaningful in a positive way for some people. Sure. Because let's face it, we're all gonna face this sooner or later. Yeah. And how we do it is as important at end of life as it is how we live our lives, the rest of the days.
Sure. Hey, Jan, I appreciate the comments we're getting. There was one comment there that I wanted you to key in on that was about hospice not causing us to. Yeah. Would you kind of? That's a good point. Would you speak to that? Lori brought up.
Yeah, absolutely. I mean, sometimes people and I was. Many years ago, I had someone ask me like, well, isn't that someone in healthcare asked me like, well, aren't you guys basically just hooking them up to a morphine drip? And then no, we don't over medicate people either, and we're not euthanizing. This is not hastening someone's death. This is trying to make the most of the time that people have left. We use pain medicines, and oftentimes strong pain medicines when needed, but we never want to take time away from patients and families by having, as soon as they're entered on hospice care, overly sedated. We're very cautious of this because it's about quality of life that they have left, and that we're I think there was some perceptions that that's what hospice does, is that we're sort of hastening people's deaths no, we're there to help those days, months, with family be as good as possible. And oftentimes that means pulling back on medications. But I'm glad you pointed that out, because I didn't see all the comments as they're coming through, and that's worth repeating.
Yeah, thanks, Jay. I'm so glad we had a chance to have this conversation and to talk about palliative and hospice care with you.
Sure. Thank you.
Thank you for all that you've done in this area throughout your career here in Sterling, Rock Falls, and in the region. So I appreciate that, and glad we had a chance to do this. And for those folks who are listening, I just based upon the comments we're getting, I know that folks are appreciative of this as well, this information. And I would encourage folks to share this broadcast with others so they get an opportunity to learn a little bit more as well. And
yeah, absolutely.
Yeah, and obviously, if you have other questions, I know Dr. Reter would be glad to entertain those too offline and everything
Sure.
too. So, hey Jay, I appreciate it, and I'll have you back again for something. I know we
Yeah,
will.
I can talk. I'll be willing to talk whenever you want about whatever you want.
I know you are. I know I appreciate
And
that about you. So
if I
thank
don't
you very
know the
much, Jay.
answer,
Appreciate it.
I'll
All right,
tell you.
take care.
Yep, and thank you.
All right, so that was good. That was good. So I'm going to give a brief pandemic update, and then I'll let you all go. So Matt will show our usual graph that we put up for our area. That's pretty similar to last week in terms of the number of cases and percentages and all that kind of stuff. So that's encouraging. Thanks, Matt. In Illinois, there are, as of yesterday, there were 503 people hospitalized with COVID versus 4,400 a couple months ago. So that's once again looking good, and the percentage positive in our state is still 1.4%, which is also really good. Cases in the U.S. are now down in the past 14 days, 19%. So at about 30,259 a day right now. Obviously, this BA2 variant is kind of slowly taking on here in the U.S. It's about 86% in the world, about 35% here in the U.S. The cases aren't more severe with the BA2 subvariant of Omicron. The vaccines for this subvariant are doing a nice job of keeping people from getting really sick or hospitalized. So that's good. And it just goes to the point that if I would still encourage you, if you're not fully vaccinated, to make sure you take the opportunity to do that, because we would anticipate that other variants will be circulating around for a while. I don't think it's that far of a reach to say that there'll probably be at least a plateauing of cases and perhaps an uptick in cases here in the next month or two with this BA2 variant. What you're reading and I'm reading as well, I am hopeful that it won't be a real significant uptick or significant surge. That's what I hope. Time will tell. For right now at CGH, yeah, just a small uptick in COVID cases, but nothing like it we've had in past times. I think right now, actually, in the area, we're probably seeing more influenza A than we're seeing COVID. And influenza A, typically, from my experience in practice, is that it's probably like a 4 to 8 week window when it kind of comes up and then begins to go back down. So we'll see if we're kind of on the downswing of influenza A. For individuals, my recommendations would be to, live your life, get out and do things, get fully vaccinated. If you are high risk, though, I would still encourage you and consider wearing an N95 or KN95 if you're in a public place until things have settled down even further. And if you're high risk and you do get an infection, I would encourage you, as soon as you test positive, to reach out to your primary care physician, your healthcare provider, and just talk through the options for being treated to prevent worsening of your illness. So primary recommendations is Paxlovid, which is over-the-counter, which is an oral pill, and then secondary are these monoclonal antibodies that we're continuing to give IV therapy treatments for here at the hospital. So if you do get sick and you're at high risk, I would encourage you to reach out and try to get one of those treatments on board so you don't get any sicker than you have to. Okay, so we're gonna come back again next week for Facebook Live. I'm still shifting a little bit in terms of what the program is going to be about, but we'll be posting it on Facebook about what the topic's going to be. I have a couple that we're kicking around right now, but we'll be firmer on that here, hopefully tomorrow or Monday. So I'll keep you all posted on that. I think we're leaning towards talking about some occupational therapy things that we have to offer patients that folks may not be aware of. Hey, for now though, I thank you so much for tuning in and taking the time to learn more about palliative care and hospice care. And I encourage you to share this information with others. And I sure hope that all of you have a great week. Thank you.